Hello students. Welcome to chapter 20th, Diabetes Mellitus. What an amazing chapter. They did a great job with this chapter in this book. Okay, so some concepts that I want you to remember is especially the statistics. Approximately 30.3 million people in the United States, which is 9.4 of the population. Let's round it up, 10% of the population are living with diabetes. And as I told you in class, probably this is not the real number because we have to consider people that are not legal immigrants, but they are receiving healthcare, right, benefits. So basically, probably they are not in the statistics. So the prevalence of diabetes increases with age. Currently, about 25% of adults age 65 and older have diabetes. Consider that one of the main reasons of having diabetes is weight gain and sedentary lifestyle. So that's why diabetes is going to be more often happening in adults. Okay, so the nature of the disease. Glucose is the primary and preferred source of energy of the body. Glucose, right? In any form, fructose coming from the fruit or any other type of glucose, right? For cells to use glucose as energy, glucose must first leave the body and enter into the cell. For this process to happen in most cells, the hormone insulin must be present and insulin receptors must function properly. And that's good to know. Insulin receptors are all over the body, but exercise can increase the number of insulin receptors on muscle cells. Okay, so if the patient has a sedentary life, probably the number of insulin receptors is going to be low. If the people start to make more exercise and do more physical activity, the insulin receptors number is going to increase, especially in the muscle cells. Okay, the B cells of the pancreas produce insulin, we know that, and people with diabetes produce very little to no insulin. That is called insulin deficiency. Ineffectively use insulin, which is insulin resistance. So when there is poor production, is insulin deficiency, and when there is ineffective insulin use, is insulin resistance, right? Meaning that the insulin is not entering the cells because of the lack of enough number of insulin receptors. That's why it's resistant to enter. Or produce inadequate amount of insulin, which is insulin insufficiency. Okay. So the difference between insufficiency is the inadequate amount of insulin versus insulin deficiency means that produce very, very little. Without adequate insulin, glucose accumulates in the bloodstream at abnormally high levels. The American Diabetes Association, ADA, we're going to call it from now on ADA, defines diabetes as a group of metabolic diseases causing hyperglycemia resulting from defects in insulin secretion, insulin action, or both. And that's good to know. Okay, so classification of diabetes mellitus and glucose intolerance. We have type 1, which is an autoimmune destruction of the pancreatic B cells. Okay, B cells. So those are the ones that produce insulin. Okay, B cells in the pancreas. Okay, so we have 5 autoantibodies causing the destruction in the majority of this population. Exactly, islet cell autoantibodies, autoantibodies to insulin, autoantibodies to glutamic acid decarboxylase, or GAD65, which is another type of diabetes that we are not going to study in this chapter. And then we have autoantibodies to the tyrosine phosphatases, and also autoantibodies to the zinc transporter protein. So people with type 1 diabetes are also at risk for other forms of autoimmune diseases, such as Graves' disease, Hashimoto thyroiditis, and Addison disease. which is your adrenal insufficiency. And we're reviewing class also that the adrenals are the little hats on top of the kidneys, right? That are in charge for glucocorticoids and mineralocorticoids. Okay, so we have the history and discovery of insulin. Feel free to read this. And then also people that are having any autoimmune condition, like I was reviewing in the last paragraph, in the last sentence of this paragraph, people with type 1 diabetes also are at risk for other forms or of autoimmune diseases. I remember I told you in class that once you have one autoimmune, it's very likely that you will develop another one, right? So celiac disease, vitiligo, autoimmune hepatitis, myasthenia gravis, which is a neuromuscular autoimmune condition, and pernicious anemia, right? The lack of intrinsic factor. So possible impact of environmental factors, the possible impact of environmental factors also are contributors, although they are under investigation. The rate of B-cell destruction determines the onset of diabetes. The rate of B-cell destruction determines the onset of diabetes. So type 1 diabetes occurs rapidly in children and adolescents. Therefore, do you remember they used to call it before juvenile onset diabetes? But may occur at any age. And in infants and children, the classic symptoms that are typically present include polyuria and polydipsia. Polyuria is the excessive urination, and polydipsia is excessive thirst, right? With almost a third experiencing diabetes ketoacidosis at diagnosis. So they are taking fat, right, to be their main source of energy instead of the carbs, right? So that is diabetic ketoacidosis at diagnosis, and they are going to find ketones in the urine. So we are going to play a video to review diabetic ketoacidosis. It's a very short video, as most of the videos that I usually invite you to watch. Okay, let's go. Here it is, diabetic ketoacidosis, diabetic type 1 diabetes.
Diabetic ketoacidosis, DKA, is an acute and potentially life-threatening complication of diabetes mellitus. DKA is commonly associated with type 1, but type 2 diabetics are also susceptible. DKA is caused by a critically low insulin level and is usually triggered when diabetic patients undergo further stress, such as infections, inadequate insulin administration, or cardiovascular diseases. It may also occur as the first presentation of diabetes in people who did not know they had diabetes and therefore did not have insulin treatment. Glucose is the major energy source of the body. It comes from digestion of carbohydrates and is carried by the bloodstream to various organs. Insulin is a hormone produced by beta cells of the pancreas and is responsible for driving glucose into cells. When insulin is deficient, glucose cannot enter the cells. It stays in the blood, causing high blood sugar levels while the cells are starved. In response to this metabolic starvation, the body increases the levels of counter-regulatory hormones. These hormones have two major effects that are responsible for clinical presentation of DKA. First, they produce more glucose in an attempt to supply energy to the cells. This is done by breaking down glycogen into glucose and synthesizing glucose from non-carbohydrate substrates, such as proteins and lipids. However, as the cells cannot use glucose, this response only results in more sugar in the blood. As blood sugar level exceeds the ability of the kidneys to reabsorb, it overflows into urine, taking water and electrolytes along with it in a process known as osmotic diuresis. This results in large volumes of urine, dehydration, and excessive thirst. Second, they activate lipolysis and fatty acid metabolism for alternative fuel. In the liver, metabolism of fatty acids as an alternative energy source produces ketone bodies. One of these is acetone, a volatile substance that gives DKA patients' breath a characteristic sweet smell. Ketone bodies, unlike fatty acids, can cross the blood-brain barrier and therefore can serve as fuel for the brain during glucose starvation. They are, however, acidic, and when produced in large amounts, overwhelm the buffering capacity of blood plasma, resulting in metabolic acidosis. As the body tries to reduce blood acidity by exhaling more carbon dioxide, a deep and laboured breathing, known as Kussmaul breathing, may result. Another compensation mechanism for high acidity moves hydrogen ions into cells in exchange for potassium. This leads to increased potassium levels in the blood. But as potassium is constantly excreted into urine during osmotic diuresis, the overall potassium level in the body is eventually depleted. A blood test may indicate too much potassium or hyperkalemia, but once insulin treatment starts, potassium moves back into cells and hypokalemia may result instead. For this reason, blood potassium level is monitored throughout treatment, and potassium replacement is usually required together with intravenous fluid and insulin as primary treatment for DKA.
Thank you so much.
Thank you for watching.
Okay,
Please feel
thank
free.
you. Okay, so this was a very nice introductory video about diabetic ketoacidosis. It doesn't matter if you didn't understand fully the concepts, because you are going to be repeating this concept through the entire nursing program over and over and over. So the most important is that you understand that when the patient does not have enough sources of glucose to produce energy, is going to look into the body in the form of glycogen, which is the glucose stored in the liver, and also is going to decompose some fat tissues to produce energy, and that is called the diabetic ketoacidosis. The excessive breakdown of the fats is going to produce ketones, okay, and it's going to be seen in the urine. So acidosis, diabetic ketoacidosis, the term acidosis is more related to type 1 diabetes. That's why the patients are having diabetic ketoacidosis. Now let's talk about type 2 diabetes mellitus. Approximately 90 to 95% of individuals with diabetes type 2, this form is most closely associated with lifestyles and environmental factors that lead to excess body fat, particularly in the abdominal region, and lack of physical activity. So genetic risk factors is a big component. Obesity and also sedentary lifestyles in diabetes type 2. Okay, so the ADA, remember, the American Diabetes Association, recommends that healthcare providers consider testing individuals for diabetes who have a body mass index above the 25 kilograms, okay, BMI better than 25, right? So a BMI of above 30 is obesity. Okay, so 24.99 to 29.9 is overweight, which is also a risk factor for diabetes. So that's one criteria, and one or more of the risk factors listed in the box that we are going to see right now. Once individuals are 45 years or older, their healthcare provider should consider testing for diabetes routinely. Okay, your A1C when you go for annual checkup, right? So two things that I want you to remember: acidosis is more related to type 1 diabetes, but also can happen in type 2, but most is related to type 1. And then type 2, most common, is happening in older adults. Okay, so okay, let's keep moving. So here are a couple of definitions: hyperglycemia, diabetes ketoacidosis, insulin. In terms of insulin, I want you to remember that insulin decreases glucose levels, while glucagon, which is another hormone produced in the pancreas, acts in a manner opposed to insulin. Insulin decreases glucose, and glucagon increases somehow the level of glucose in the body by requesting the release of glycogen from the liver. Okay, so the liver also participates in this operation. Unlike type 1 diabetes, an autoimmune response does not cause type 2 diabetes. So, meaning type 2 is not autoimmune. This form of diabetes results from insulin resistance and in some cases leads to insulin insufficiency. So that's the difference between type 1 and type 2. One is autoimmune, the other one is the consequence of insulin resistance and insulin the insufficiency. Either the body is unable to use the insulin produced effectively, or the pancreas produces inadequate insulin to cover the glucose load. Some people with type 2 experience both insulin resistance and insufficiency, and these individuals at the beginning do not need exogenous insulin for survival. Rather, they rely on healthy eating, exercise, and oral medications for disease management. Type 2 diabetes is a progressive disease, and many clients eventually need insulin to manage their glucose levels. So I want to make a comment on this. So let's do some critical thinking. If you have insulin resistance because you don't have enough insulin receptors, right, in the body, and then or you have insulin insufficiency, now you need to administer insulin, right? Exogenous, meaning external insulin. But okay, that is not solving the problem of the lack of insulin receptors. Yes or no? Okay, so that's why they are saying that exercise increase the number of insulin receptors. So you can keep adding more and more insulin injection, but the problem is that the receptors are not enough to absorb that insulin. At the end, you're going to end up with a lot of insulin in the system. And I know a patient, a lady who passed already like 5 years ago. She was in ICU because they thought she was having a lot of, she was having fluids in the lungs, pleural effusion, right? And what happened is that, yes, she was having a pleural effusion, but they found that this fluid was a collection of insulin. So there you go. You can run that risk. So in other words, what I'm trying to tell you is basically the good method of treating this is to practice exercise, because we need to increase the number of insulin receptors in order to absorb either our natural insulin or the exogenous insulin that is being administered. Okay, consider that thought. Okay, so now let's go to see risk factors for type 2 diabetes. We have on the left side the non-modifiable risk factors, and on the other side we have the modifiable risk factors. So non-modifiable, the first one is the first degree relative with the, okay, so this is hereditary genetics, right? And the other one is modifiable risk factor is the BMI bigger than 25. Okay, so those two, on one of each side, the top one, those are the two main factors that influence the development of diabetes type 2, hereditary and the weight. So consider your family history, your mom, your dad, even your grandparents, right? And also observe if you're having overweight or obesity, right? And then you can consider the non-modifiable, the age, your race or ethnicity, okay, in the modifiable risk factor, your sedentary lifestyle, high blood pressure, history of heart disease, LDA, high triglycerides, and try to think about if you are suffering from metabolic syndrome, okay? So, and that's a concept that we learned in previous chapters. Many adults and children type 2 diabetes can improve their symptoms with weight loss, okay, healthy eating, and increased physical activity. Again, the target is to increase the number of insulin receptors. There are several tools available for healthcare providers and the public to determine an individual risk for developing prediabetes or type 2 diabetes. Now let's talk to gestational diabetes. Occurs during the second or third trimester of pregnancy. Second or third, okay? With normal blood glucose control, usually recover after delivery. And pregnant women who have pre-existing type 1 or type 2 before conception do not fall in this category, okay? So if they already have it, they don't fall in the category of gestational diabetes because they had it. So gestational diabetes presents complications for the mother and the baby if the pregnant woman does not carefully monitor and manage her glucose levels. Persistent hyperglycemia is associated with an increased risk for intrauterine fetal death and macrosomia. And macrosomia is a condition where a fetus or newborn is much larger than average. So try to absorb this knowledge, because when it comes the time you are going to have your OB classes, this is fundamentals in that class, okay? Your gestational diabetes definition, and macrosomia, and the risk for the death of the mother and the fetal if they don't control hyperglycemia. So this table is presenting the differences between type 1 and type 2. In type 1, the ethnicity, right, is more North European. Type 2 is Native American, Hispanic, African American. The age in type 1 is younger than 30. In type 2, generally older than 40 years. But, you know, depending on the risk factors and the stressors and the environmental, it could develop in the early 30s. Weight, usually normal or underweight in type 1. And in type 2, obesity is a risk factor. Treatment in type 1 is insulin required. They are going to survive with insulin pump. And type 2, modest weight loss. Goal is 5% to 10% healthy eating and increased physical activity. Typically start with oral hypoglycemic agents, and the treatment of choice for diabetes type 2 based on the algorithm of the ADA is to start with metformin, and then increase the number of medications to the point that you can include insulin for glucose management. And then type 1 is B cell functioning, right? Insulin deficient and may develop insulin resistance based on lifestyle choices. And type 2, in terms of B cell insulin resistance, that may lead to insulin insufficiency, right? And then you have some cultural considerations. Adults, the CDC and Prevention Center for Disease Control monitors the prevalence of type 1 and type 2 diabetes among racial and ethnic groups in the United States. So here you have an interesting statistical table. You can see the red represents the woman and the blue the men. So you can see huge numbers in terms of American Indian and Alaska Native, especially in terms of women. And then in terms of Asian, the percentage of diabetic patients is higher in men. And then in Black non-Hispanic, the percentage is higher in women. And then you can keep Hispanic is in terms of men, is the number is high, right? So the healthcare provider will diagnose women who meets the diagnostic criteria for diabetes at this time with diabetes, usually type 2. And we were talking about gestational diabetes, remember? And we were mentioning that in terms of gestational diabetes, persistent hyperglycemia is associated with an increased risk of intrauterine fetal death and macrosomia. So then we discussed some tables, but going back to the gestational diabetes, the healthcare provider will diagnose women who meet the diagnostic criteria for diabetes at this time with diabetes, usually type 2, rather than gestational diabetes. Okay, and that's good to know. In summary, women with history of gestational diabetes are at high risk of diabetes type 2. Those that present with gestational diabetes at the moment of pregnancy, right? Not with a previous history of diabetes before the pregnancy, just to make it clear. Okay, so those that are having gestational diabetes are at a high risk of diabetes type 2. All women who are not otherwise known to have diabetes or who are at high risk should be screened with a glucose tolerance test between 24 and 28 weeks gestation. Okay, the first line therapy to manage blood glucose levels for women with gestational includes medical nutrition therapy, physical activity again, and self-monitoring of blood glucose. Recommendations include frequent testing and the following goals: fasting glucose less than 95. We are talking about gestational diabetes, so the glucose levels in this type of diabetes during pregnancy are different from the other groups. Okay, so fasting glucose, it has to be less than 95, and 1 hour postprandial, so 1 hour after meal, less than 140, and 2 hours after meal, less than 120. Okay, so fasting less than 95, 1 hour postprandial less than 140, and 2 hours later is less than 120. Okay. If blood glucose levels consistently exceed the goal level, then the first line treatment starts with insulin therapy. So if these numbers are above the expected, insulin is going to be administered. In the past, healthcare providers avoided prescribing oral hypoglycemic agents for women with GDM, gestational diabetes, for fear of teratogenic effects. However, if the individual with gestational declines insulin use or cannot afford insulin, because remember insulin is expensive, or if the team is concerned with the client's ability to safely use insulin, then they may consider oral medications. So this is a benefit versus risk discussion, and a team, a group of doctors are going to meet and decide what they are going to do. Diabetes management guidelines also advise women with gestational to diabetes to maintain a healthy body weight and weight gain pattern. Okay, and significant risk for having subsequent pregnancies that are complicated by diabetes and for developing type 2 diabetes later in life is present, so the complications are there. Okay, other types of diabetes, we have monogenic diabetes syndrome, which is a defect in the B cells or insulin action. We have pancreatic conditions or diseases. We know that the pancreas is releasing insulin and glucagon, so tumors that affect the islet cells, or acute viral infections by a number of agents such as mumps virus, acute pancreatitis for biliary disease, gallstones, alcoholism, you name it, put the patient in risk for developing diabetes related to the pancreas condition. Endocrinopathies also. Hormones such as growth hormone, cortisol, glucagon, and epinephrine are all antagonists to the functions of insulin. Again, hormones that such as growth hormone, cortisol, glucagon, epinephrine are all antagonists to the functions of insulin. Antagonists. Now, Cushing syndrome, glucagonoma, pheochromocytoma, and hyperthyroidism may suffer from hyperglycemia resulting from excess production of insulin antagonist hormones. Now we have another type is drug or chemical induced diabetes, and includes the use of steroids or immunosuppressive regimens after organ transplantation surgeries to prevent organ rejection. So the following drugs and toxins has been linked to impaired glucose tolerance and diabetes in susceptible individual. So Vacor, which is a rat poison, petaminide, which is a nicotic acid, also glucocorticoids, thyroid hormones, thiazides, diazophenotine, which is dilantin, B adrenergic agonist, and A interferon. So we know that Cushing's syndrome also is known as hypercortisolism. It's a hormonal disorder that occurs when the body is exposed to too much cortisol. So glucagonoma, the other one that I mentioned previously, is a rare pancreatic tumor that causes the body to produce too much of the hormone glucagon. And pheochromocytoma is a rare tumor that forms in the adrenal glands and causes the body to produce too much adrenaline and norepinephrine. So in one we have the cortisol issue, the other one is related to the pancreas, glucagonoma. And then we have the pheochromocytoma, which is related to the adrenal glands. Okay, so different organs that could cause this diabetes to develop, right? And then let's talk about impaired glucose tolerance. So the ADA identifies individuals whose fasting blood glucose level is higher than normal, meaning that they are higher than 100, right? But less than the level for the clinical diagnosis of diabetes. So less than 126. So it's between the normal is less. Let me review this again. The ADA identifies individual whose fasting blood glucose level is higher than normal. So it's higher than 100. That's higher than normal, which is sometimes they are still debating and this is still changing. But sometimes they define the lowest 70 or 80, right? So it's higher than normal, but less than the level for the clinical diagnosis of diabetes. So 70 to 126. Others say 70 to 100 and 110. So 126 is the borderline, right? The upper limit. And then, or it could be the H1C of 5.7 to 6.4% as impaired glucose tolerance, right? Which is also defined as prediabetes. So when you hit a little bit more or close to 126 is considered prediabetes, okay? So impaired glucose tolerance, prediabetes, more than 100 and less than 126 A1C, 5.6 to 6.4. Those are the average numbers, right? You need to remember that. And then ADA recommends testing for the impaired glucose tolerance test beginning at 45 years old for all individuals, regardless. Okay, everybody 45 and older, they need to do the intolerance glucose test, right? Or early if individual has a BMI of more than 25. So if your BMI is in the obesity or overweight section. So you have to do it, okay? One or more risk factors for diabetes type 2, for example, high blood pressure. Do you remember that table we reviewed a few minutes ago? One or more factors of diabetes type 2. Let me see, here is. So you have the sedentary lifestyle, high blood pressure, history of heart disease, low HDL cholesterol, which is your happy cholesterol, okay? If you have low HDL, it's a risk factor. If you have high triglycerides or high LDL, it's a risk factor, okay? So And we know the numbers for the happy cholesterol, right? So those are risk factors. Okay. Let's see, where were we? Okay, if results fall within the um, IGT range, fasting blood glucose of 100 to 125, right? The healthcare provider should screen clients annually. So the intolerance of the glucose test is a strong risk factor for the future development of type 2 diabetes and cardiovascular disease. The Diabetes Prevention Program, DPP, Diabetes Prevention Program, demonstrated that overweight adults with intolerance glucose testing could reduce the risk for developing type 2 by 58%, with moderate weight loss 5 to 10% of body weight and regular physical activity at least 150 minutes per week. So here is another secret, right? You can reduce, right, your risk for developing type 2. First of all, if you, okay, so the main risk factors are hereditary, and if you are overweight or obese based on your BMI. Those are the main risk factors for developing type 2. Now, you can reduce, right? You can reduce the risk for developing type 2 if you lose weight, moderate weight loss, 5% to 10% of body weight, right? Let's say your weight is 160, so 5% would be 8 pounds, and 10% would be 16 pounds. You can reduce the risk. And also, if you practice regular physical activity, like around 150 minutes per week, that is going to not only help you to reduce weight, but also to increase the numbers of the insulin receptors in your muscles. Okay, so you kill two birds in one shot when you do your physical activity. You lose weight and increase the number of insulin receptors. So aerobic exercises, right, and resistance training, okay, it's not regular walking when you don't sweat anything and you're walking at a pace of 1 mile every 5 hours, right? You need to do some, very fast walking. Okay, so aerobic exercises, which is a moderate activity, right? And resistant training are particularly important aspects for treatment because they increase insulin sensitivity and glucose utilization in skeletal masses. So you are putting, especially in your resistant training, a lot of effort, and your muscles are getting strong, and the number of insulin receptors is going to increase. So then individuals with intolerance glucose testing often have a complicated assortment of underlying conditions. For example, those that are going to fail that test, they are going to be having dyslipidemia, obesity, hypertension, chronic inflammation, all goes together. Obesity, high cholesterol, hypertension, they all go together. And that build one on one another to create a condition known as metabolic syndrome, right? All go together. Obesity, you see distended abdomen, right? You have hypertension, high cholesterol, or high triglyceridemia, right? And probably high glucose levels. That's your metabolic syndrome. Okay. More physical activity and less sedentary behavior can help reduce risk factors for many chronic diseases of adulthood, including diabetes, cardiovascular disease, hypertension, and metabolic syndrome. So we know that several lifestyle interventions programs based on the original DPP, which is your diabetic prevention program, are available to help individuals implement and sustain model weight loss and prevent or delay the onset of type 2. And that's good to know also. The priority for preventing diabetes is to achieve moderate weight loss. Again, I keep repeating this 1, 2, 3 times. So we need to lose weight and increase activity. And of course, we need to lower calorie intake in order to reduce weight, right? So lower calorie intake goes together with moderate weight loss, and increase physical activity. So we are going to stop here. This is our diabetes chapter 20 part 1. When we come back, we are going to talk about the symptoms of diabetes and laboratory tests. Thank you.